Good evening, my name is Ioana-Irina Rezuș, and my PhD title is Management of Pancreatic Cancer from Diagnosis to Treatment. I'm a first-year radiology resident with a vision to have a better management for patients with pancreatic cancer, and for that my mission is to assess new diagnoses and treatment methods and implement them into healthcare. I have two ongoing projects. The first one started in September and the second one started in December last year. And the first one is about the efficacy and safety of therapeutic procedures for chronic pain in patients with unresectable pancreatic adenocarcinoma. Pancreatic adenocarcinoma is currently the fourth leading cause of cancer-related death, with almost more than 80% of the patients diagnosed with unresectable disease, and almost as many have pain from the point of the diagnosis and through the rest of their lives. Unfortunately, the available medical treatment consists mostly of opioids and is still associated with inadequate pain relief in more than half of the patients. But there have been emerging more interventional ways to address this pain, and our aim is to find the most efficient method that exists for this type of chronic pain. So we have the question, which method is more effective and safer for pain management in patients with unresectable pancreatic adenocarcinoma? And we frame it as a PICO, with the population being adult patients, interventions and comparators being any type of pain management from medical to interventional. The primary outcomes are pain relief and quality of life, while the secondary outcomes are adverse events, survival, and analgesic drug use. And we decided to include only randomized controlled trials. Our hypothesis is that interventional radiology methods can provide a better chronic pain management. We performed our search on the 29th of October last year with the search key you can see on the left side in 5 major databases, and from almost 5,500 articles we reached the number of 27 eligible full-text articles. We have more outcomes. We have today some results for pain, and the other outcomes are under analysis. Pain was our primary outcome because pain is the most debilitating symptom in patients with unresectable pancreatic cancer. We decided to evaluate pain at more time points because we wanted to see the dynamic of pain from and under treatment. Usually pain is assessed on the visual analog scale, which ranges from 0 to 10, with 0 meaning no pain and 10 being the worst pain possible. So of course, the lower the pain score, the better is the result of the intervention. At 4 weeks, we have included 5 studies that in total have almost 270 patients. And we could make 3 groups of interventions. There is the endoscopic ultrasound-guided neurolysis and the percutaneous neurolysis, which are one-time interventions after which at different time points the outcomes are measured. And we have the opioids group, which mean continuous treatment from the point of the randomization with patients taking daily doses of opioids. The heterogeneity is rather high with 89%, and this could come from differences in the techniques or from the locations of the tumors, as body and tail tumors are known to be more painful as the head tumors. If we look at the results, we can see that the overall pain for percutaneous neurolysis is 2.17, while the overall pain for opioids is 2.68. This means that in both treatment groups, the therapeutic procedures had a good pain control, because it keeps the pain in a rather low score. However, the difference between the two groups is not clinically relevant. If we compare these results to the pain assessed at 12 weeks, we can see we have a new study included in our analysis, the GAO study. And we can see that both in the second and third group of treatment, the pain is a bit higher. We can say almost in the high, it raised in the same speed, with the same speed. And again, the difference is not clinically relevant. If we look at the pain score for the US guided neurolysis, indeed it's lower. However, the number of studies included in that group is also low, so we could not draw a definite conclusion. When we assess the adverse events, we can say that the so-called more direct approaches to the plexus, such as the US-guided and the intraoperative neurolysis, are associated with a lower rate of adverse events compared to the percutaneous neurolysis. And if we take into consideration nausea, vomiting, and constipation, which are known to be associated with the opioid treatment, it is logical that patients randomized to the pharmacological treatment group have a very high chance to develop these adverse events, while patients randomized to the interventional therapies don't have so many chances. The strength of our study is that it includes various types of procedures, and the outcomes are measured at different time points. And we also included only randomized controlled trials. However, the low number of studies is the biggest limitation, and there is a high heterogeneity among the procedures and also among the measures of effect these studies used. To conclude, the minimal invasive procedures provide pain reduction with fewer associated adverse events, and this is why they should be considered in treating the pain of unresectable pancreatic cancer patients. But we need further RCTs comparing directly these interventions among them, and also comparing one-time interventions with multiple repetitions of the same intervention. This is the progress of my first project. We are waiting for additional figures and tables, and after that we will start drafting the manuscript. The second topic is about the detection rate of different imaging techniques in pancreatic cancer early diagnosis. Because as we know, the pancreatic cancer has a very poor prognosis, and resection is the only chance of cure. If we look at the 5-year overall survival rate, it is very low with only 4.6%. But if we look at the 5-year survival rate for tumors smaller than 2 centimeters, it is 80%. So there is a small window of hope to diagnose as early as possible these patients and send them as quickly as possible to surgery. And the most common identification techniques are endoscopic ultrasound, CT, and MRI. And our aim is to find the best performing technique in the early diagnosis. Because when we talk about the early diagnosis, we have two major populations of patients. The first one are the asymptomatic ones, so-called at risk, and we can stratify this risk in a high and in an intermediate risk. And then we have the symptomatic patients that are suspected of pancreatic cancer, but they still have tumors smaller than 2 centimeters. So we raised the question, which imaging technique has the best detection rate for early pancreatic cancer? And we frame it as a PICO with the adult patients stratified in two. The interventions are radiology examination, the comparator is the pathology, and the outcome is the early diagnosis, with the hypothesis that one intervention provides better results than the others. And the most important clinical implication would be, of course, an increase in survival, while also for the policy making, it will be a decrease in the number of unnecessary investigations. There are already some published meta-analyses on this topic, but they focus mainly on the difference between EUS and MRI for the at-risk patients. Our search key will have 4 subdomains. The first one about pancreatic cancer, the second one about the imaging techniques, the third one about the identification concept, and the third one will be about randomized controlled trials and comparative studies, as these will provide the highest quality of evidence. At this point, we finished checking the feasibility of this study, and we will continue drafting the Prospero after. To conclude, I have 2 ongoing projects. I hope to finish the first one by April this year and the second one by the beginning of summer. And I will leave you with a quote from George Bernard Shaw, "Don't wait for opportunity, create it." Thank you.
I was listening, and I probably was not listening well enough. But what is MRAW?
So it's the raw mean. I actually don't have any more knowledge about this, but it's the mean. It's the mean pain.
Do we have a statistician here? That's good. Okay. So the next question is then, if I want to put this result in context, so this is the average pain score at week 4. Mm-hmm. If I want to understand,
you would need the baseline
values. That the intervention worked,
yes.
I want to see the pain at day 0, so before yes. the intervention took place. Because if it's 6 and then it's 2.1 in the percutaneous neurolysis group, then that's a very effective treatment. But if it's 2.5 and then it turns into 2.17, then I'm not sure if that's a good treatment. So you surely need a forest plot of week 0 for all of these studies if you want to kind of interpret the results of these
I know, and it was that we didn't get the results on time, but I checked last night so that I know. The idea is that anyway, so in all cases, also for the neurolysis, also for the pharma, the pain is lower, but it's lower almost with the same difference. Because these are randomized controlled trials, they start from almost the same pain and get to almost the same pain. So in all of the cases, there is a change, but there is not a difference in those changes.
Between the two?
Between the neurolysis and the pharmacological treatment, yes. Yes. Because I also was curious about this, and when I saw this plot.
What would be also interesting to see so that means both therapy is effective.
Exactly.
They are effective.
On a short term, and then on long term.
But if I am told that you've got cancer, for your pain I can give you an injection into your neuron which then resolves the pain, and that happens 6 weeks once. Or you can take a lot of drugs and you will be sleepy and nauseous and whatever. So what would be nice to see, in addition to the effectiveness of the treatment options, to see the downsides, complications, risk of adverse events.
Yes, exactly. This is why we showed the adverse events like this, because we didn't get the results from the statisticians yet, but we wanted to highlight this part.
What is also quite interesting for me that you didn't find any more articles in the EUS interventional group, because it's not a new one, but maybe the interventional gastroenterologists are quite lazy and we are not writing articles.
We have actually 2 or 3 additional articles, but they couldn't be pulled together with these ones because of how they reported the statistical analysis. And it's very sad because I wanted to see those results.
It's the best treatment.
I want to say that too, but I couldn't say because we didn't have enough.
Is there a reason you did not include a stereotactic radiation therapy?
There were no randomized controlled trials with it. Because when I was thinking about this topic, I had very high expectations of many randomized trials, but they weren't that many.
So congrats, brilliant presentation. Just out of curiosity, I can see here only neurolysis and opioids. So isn't there any other available method of intervention for pain therapy, or you didn't have enough data for it?
There are, and they are expanding, but we didn't have randomized controlled trials with them. But there are actually radioablation, microwave ablation, cryoablation, stereotactic, irreversible electroporation. There are many, but I think they will be further analyzed in randomized controlled trials, hopefully.
Congrats on your presentation. Regarding your first project, do you see also an indication in the case of borderline resectable pancreatic cancer? So only before the surgery, the patient gets neoadjuvant therapy. And do you also see an indication to use these interventional techniques there?
So in this meta-analysis, we focused on unresectable. But me personally, I think it would be a good idea to use it. But it's just my opinion. I didn't find articles because we actually excluded the ones that were not including only unresectable pancreatic cancer.
Congrats for your presentation. I have one short question. Neuroendocrine tumors of the pancreas can be hard to diagnose as well. So regarding your second topic, do you wish to include them as well?
So in the initial state, I think we will include everything. However, I think it will be a too heterogeneous population. So I think based on what the results we will have, we will decide after that.
Regarding your second project, what is the main difference between your project and the already published meta-analysis?
So we want to have a subpopulation of asymptomatic and one of symptomatic. What I've seen is that they focus only, for example, the risk for the screening, for the patients at risk and asymptomatic. But we want to somehow include and make subgroups and compare and bring them together.
And you also would like to investigate the effect of CT scanning?
US,
screening.
MRI, and CT, these are the most common, but if we find any other articles that fit our criteria, we will also look for ultrasound, for example, if there are results.